Hi, okay, so a little video about medications in relation to alcohol withdrawal, but also in maintenance prescribing. Um, First thing to say, there's a few things to say about this. The UK isn't very good at prescribing. Obviously, there are some great prescribers out there, but there aren't many of them. So in the UK, we tend to have a policy more of not prescribing when actually we could prescribe and that would be very helpful for people. So we've got a little bit of a problem. So this is area specific as well. So what we're seeing more and more of, so each county will have a slightly different policy on this, although I think the general policy is probably at least UK, England specific. So the current policy is that any alcohol prescribing, whether that's withdrawal or maintenance, is to be done through specialist prescribing service. Sometimes that's very appropriate. However, quite often it's very appropriate for a client's GP to do this prescribing. And that has happened historically, whereas now GPs are being told more often than not that they are not allowed to prescribe. So what you've got is you've got some GPs that are willing to do it because they have got the knowledge and experience and they're willing to take the risk, or they've got access to a really good psychiatric consultant to take advice from. And you've got some GPs that are just following what they've been told and they're like, no, I'm absolutely not going to do this. So in terms of NHS world, this is very hit and miss. It's incredibly frustrating for clients, very frustrating for professionals when you can see that actually this is really going to help. So yeah, it's actually really quite difficult and frustrating and disappointing. But there are some private prescribers out there, and I have had conversations with some. I do not have a preferred private prescriber that I work with at the moment. If I do get one, I will let you know. If you're working with clients, I highly recommend that you, if you're doing this type of work, you're working with people that might get a little bit stuck, to seek out links with a private prescriber if that's appropriate for the work that you're doing. But let's start with alcohol withdrawal. So as we talked about in the training, sometimes people will need medication to help them detox off alcohol. Remember that alcohol is a physically and psychologically addicted drug. So sometimes what will happen is, obviously people are physically addictive. They could reduce slowly, they absolutely could, but not everybody is able to do that. If they can, great, by 1 unit a day. But some people really struggle with symptoms, so lack of sleep and anxiety, paranoia, hallucinations, all that stuff. And sometimes actually there is quite a risk associated with withdrawal, so medication is appropriate. It's different levels to this. So there are people who I would love to do a medical home detox. So go to your doctor, talk about your prescribing options, get a 2 to 3 week reducing script of chlordiazepoxide, Valium, depending on what's relevant. So the medication, it will be a benzodiazepine of sorts that they get prescribed for withdrawal. Incredibly effective for withdrawal, just amazing. It can make it really easy for people. However, doctors don't like prescribing benzodiazepines, as I'm sure you're aware, for good reason. But in this situation, a 2 to 3 week reducing script with support can really help. What the doctor decides to prescribe will depend on their age and their gender and other physical health issues as well. They may decide to prescribe thiamine too, depending on, again, physical history, the amount they're drinking, and the doctor will decide on that. They might already be being prescribed thiamine. That's quite common. People who are drinking are already being prescribed thiamine. So it's really nice if somebody can go to their GP, they're struggling to reduce, they're struggling with symptoms. Anxiety is the big one actually that gets missed quite a lot in terms of withdrawal. So what you tend to see is people sort of bouncing backwards and forwards, not able to do it, and it's the anxiety that stops them. Sometimes this is a withdrawal symptom, and this is where a benzodiazepine can be absolutely amazing and really help with support, obviously. Now, sometimes people will go to a detox centre, so either they will pay to go and do 2 to 3 weeks in a detox centre and they will be prescribed their medications there. Sometimes people will have an emergency detox. So an emergency detox is when obviously it's an emergency. So hospitals are able to do emergency detoxes. They don't like doing them, but it is in the NICE guidelines. Obviously that's going to be very difficult at the moment with a lack of beds, and that tends to be what I see happen around emergency detoxes. It's dependent on the beds. I have seen people be turned away that really should not have been turned away, so you're looking at an emergency detox if it's a matter of life and death, and then the hospital will do the prescribing. Now, if it's an emergency detox, what can happen in hospital is they're in for 3, 4, 5 days, and then they're discharged, and they might still be having withdrawal symptoms. They might be discharged with a prescription, they might not. I like them to be discharged with a prescription. So if you're working with a client that's in hospital, liaising with a local GP, liaising with a hospital prescriber to encourage that 2 to 3 weeks reducing script. It tends to be a handover between the hospital prescriber and the local GP, so that comes down to all sorts of stuff as to whether people are willing to do it. Okay, I've come across hospitals where people do give a prescription, which is lovely, and I've met GPs that are happy to pick up that prescribing as well. Very hit and miss. I'm going to say that a lot, aren't I? But that's pretty much the score in the UK. It's very different in different countries. Depending on the prescribing, it tends to be a lot easier pretty much everywhere else from what I've seen. So sometimes we might need to liaise with a GP. That will be dependent on your knowledge and experience and skills. Please don't do this unless you feel able to do it. But inpatient detox, they will pick up the prescribing anyway, and then if you're supporting that client, you will be part of the aftercare plan, so you wouldn't need to worry about the prescribing. But just, for withdrawal, 2 to 3 weeks, reducing script of a benzodiazepine, bloody fantastic, takes the withdrawal symptoms away, takes the anxiety away, sleep isn't normally an issue. If the prescribing is done right, people sail through it, and as we all know, those first 2 to 3 weeks can be the hardest. So it's lovely. When I have worked with clients with GPs and private prescribers and we've done this, bloody brilliant results. Yeah, but people can reduce as well. So I've also worked with clients where it's clear that they have a physical addiction. We've not been able to get the prescribing sorted, so we've had to do a reduction, still get great results. Okay, so also, the other thing about medical detox is NICE guidelines say 1 medical detox a year because of the impact on the body in terms of detox. There are prescribers that will do more than 1 a year. I have met people that have multiple detoxes, but again, this is down to the risk of the prescriber. A lot of people won't do it. For instance, if you work with a client 3 to 4 months ago, they had some prescribing, they need some prescribing again. Most prescribers will be like, no. But they'll weigh up the risks as opposed to the risks with the drinking, the risk to prescribing. So people do die in detox as well because of the strain on the body, the strain on the heart. Okay, so it's not that, although medical detox is great and I've had some amazing results, there have been clients that have died as well. There are clients that die in withdrawal too. So very, very risky. Just risk all round, isn't it? It's much better if people don't drink, as we know. Okay, maintenance prescribing. So there are a number of different options here depending on what type of drinker the person is, but also the prescribing will be dependent on the prescriber, what they're willing to prescribe, that person's medical record, and also their other medications that they are prescribed to. So it's not clear cut here either. Now, my experience with maintenance prescribing is that, again, GPs are even less likely to prescribe maintenance prescribing than they are detox. However, sometimes if you can link them in with a local psychiatric consultant and they have a conversation, they will do it that way. Now, yes, people can be referred to specialist treatment services and they may or may not get an appointment with a specialist prescriber. Again, hit and miss. Everybody should have the option of seeing a specialist prescriber, but unfortunately it doesn't work like that. There's a lot of gatekeeping that goes on that's a little bit worrying. Well, it's not worrying, it's about waiting times and availability and stuff like that, and some services really are struggling. So then you know what that's like when people are struggling. It's quite difficult, isn't it, to get through the door. And specialist prescribing seems to be one of the hardest things to get to. But if your GP has a good relationship with a specialist prescriber, then, you know, the GP can have a conversation, they can sort of liaise that way. Now, the other issue is, in my private work, quite a lot of people do not want to go to specialist treatment services. And this tends to be a little bit of a blockage. They much prefer to liaise with their GP, and I'm a massive advocate of that. We did lots of work on GP prescribing many moons ago. There are so many benefits to it. However, there's a real split in the community as to the efficacy of that. But I'm a big fan of GPs prescribing with specialist support. I've seen it really work. And also it's that availability, you know, it's that normalisation of services. When you think about most people that have a drink problem, they're not really going to walk through a treatment service door. They don't really want to. They can, but they don't want to. Okay, so maintenance prescribing, number of different options. So antabuse, I can't say this word now, disulfiram, disulfiram, I think. I'll put some links with this video anyway. So antabuse, commonly known as, is usually the most unlikely one that anybody's going to prescribe. So yes, people can get antabuse. Again, depends on the prescriber. The problem with antabuse is if you drink on antabuse, you can be very unwell, and there have been some deaths. So again, this is that risk element in terms of prescribing. Prescribers not happy about prescribing a drug to drinkers, and if they drink on it, they die. You know, the prescriber can lose their registration. So antabuse is not popular at all for that reason. However, it works for a very certain personality type. So if you're the type of person that if you take a drug and you can't drink on it because you know the risks are really high, then that works. Whereas if somebody's a risk taker, not necessarily going to work. So there's some stuff there, but also, you know, it's about other medications, what type of drinker you are, your physical health. There's lots and lots of different factors involved in terms of choosing a maintenance prescribing. I have worked with people that have been on antabuse and it's been fine, but it is a very specific type of drinker. These are maintenance prescribing, so this is about when you're alcohol free and you want to stay alcohol free. Campril or a Camprosate. This can be good for reducing cravings. Again, this is for helping you remain alcohol free. Very hit and miss results I see with this one. I see some people doing very well with it and some people are like, I don't notice the difference. And this is one of the reasons why prescribing, one of the many reasons why prescribing isn't that popular in the UK, is because we don't have a great evidence base for it. But there could be many reasons for that, in, you know, just the fact that we don't do very much of it. But over the years, I see like 50-50 with the Camprosate. So I don't see many people prescribed antabuse, but when they are, it tends to work more. I'm guessing that's because you're more specific about who you're going to prescribe antabuse for. It's, you know, whereas a Camprosate is slightly different. I think there is something about the placebo effect as well with a Camprosate. So for some people that's going to work. So yeah, and also some people have reported that it helps in terms of leveling out their mood, and I've worked with some prescribers that really like acamprosate. They like the results they're getting with that. Then you've got naltrexone and nalmefene, which are very, very similar. So naltrexone and nalmefene are not for daily dependent drinkers. It's not for being alcohol free. It's more about reduction. It's more, so think your binge drinkers, think people that just want to drink less, but you know they're really struggling to do that. So nalmefene and naltrexone are opioid blockers. So what they do is they stop you from getting that hit from alcohol. There's also been some stuff, I think it's nalmefene, they're doing some research where it's also working for gambling and other types of addiction. I don't know a huge amount about that, but I've just seen something about it. So I've got a friend who's a prescriber, and he is really favouring using nalmefene, says he's getting great results for that at the moment. I have also met and worked with people who use naltrexone. Again, very hit and miss in terms of the results. For some people it's really working for them, and for others it's like no. What I tend to see is it does definitely reduce the amount that somebody's drinking. So I'm thinking about a couple of clients recently that I've worked with. So I remember a lady who was pretty much alcohol free. She would probably have a drink like once a week, but when she drank too much and she didn't really want to do that, and she'd pretty much tried everything and she'd really worked it. She did naltrexone and she did the Sinclair method, and it worked really well for her. And then there's another lady more recently, again, pretty much alcohol free, will have the occasional binge, doesn't want to binge. So she has done the Sinclair method as well and used naltrexone and is drinking less. However, she feels that it's not really working, but I would argue that the evidence is, well, she's drinking less when she binges. So I think there's something about expectations there. Maybe she was hoping it would help her stop completely, but what it does is it helps you reduce the amount you're drinking. So as you can see, for some types of drinkers, that can be very, very beneficial. You know, imagine you're a binge drinker and you've pretty much tried everything. I mean, binge drinking can be really dangerous for lots of different reasons, and you take naltrexone and you just automatically drink less. Bloody brilliant. Yeah. It's supposed to be used in conjunction with a reduction plan. Unfortunately, what I tend to see in the UK with a lot of prescribing with naltrexone and nalmefene is it is not. But I think that's where the Sinclair method comes in. But I see mixed results with all of it. Yeah. So I hope that gives you a little bit of an idea of what they are. Any questions, please ask. See you soon.